So today, I'm going to talk to you about a few things that you've already heard and hopefully a few new things. But mostly I'll talk about how to diagnose the MPNs and a little bit about treatment options. And since we've heard a little bit about this already, and because you guys have just had lunch and everything, we can maybe make this a little bit more interactive. So if you have any questions, definitely feel free to interrupt. I'm looking at you. And then we'll have time for questions after lunch, after this as well. So here's my conflict of interest for my research. So today, as I said, we'll be discussing a little bit about what the MPNs are, and specifically I'll talk about PV, ET, and myelofibrosis. I'll speak about diagnosis and a bit about treatment, and then a little bit more about outlook. So what are the MPNs? As we've been hearing all day, myeloproliferative neoplasms are disorders that initiate in the bone marrow itself, in the stem cells, and they're classified, as the name implies, proliferative, as too much of something. So for polycythemia vera, it's too many red cells. For essential thrombocytosis, it's too many platelets. And then myelofibrosis kind of gets joined into this as well, because both PV and ET can result into myelofibrosis. And in fibrosis, there's a lot of scarring. So there's some common features in the MPN that make them fall under the same category of diseases. As I said, the bone marrow biopsy itself is making too many cells. And the bone marrow biopsies themselves can have some similar characteristics in their morphology or how they appear under the microscope. In order to diagnose an MPN, we have to rule out other causes of high blood counts. It was mentioned before, not just because a patient has high blood counts of some variety means that they have an MPN. And the main thing that they really share is genetics, which I'll talk more about, and a risk of transformation to myelofibrosis and to leukemia. So who's JAK? We've been hearing about genetics all day. So although each of the MPNs is different, they do share similar biology. They share similar genetics. And as has been said, mutations are genetic mistakes. These are not things that patients are born with. These are not things that patients inherit to their children, although there's some rare groups of patients that have clearly a hereditary predisposition. In general, the MPNs are not thought of as genetic diseases and that you inherit them or pass them on. So these mutations occur in the stem cells in the bone marrow, in the seeds that make your plants, like was said before. The most common of the mutations is the JAK2 mutation. And so about half of patients with ET and half of the patients with myelofibrosis will have a mutation in JAK2. Most patients with polycythemia vera, and really the overwhelming majority, greater than 90% of patients, will have a JAK2 mutation. But there are other mutations that have been recognized more recently, such as the calreticulin mutation and the MIPSS mutation. And these mutations really only occur in ET and, or for the most part, in ET and myelofibrosis. So why do we care so much about the genetics? And what does this really mean for you as patients and for the doctors treating you? So as was sort of described before, but I'll discuss it a little bit again, every cell learns from what's going on in its environment through receptors on its surface. And these receptors help to communicate with the cells in the bone marrow to say, we have too many cells, we don't have enough, make more, make less, etc. And so when the receptors on the surface are working fine, the cells know when to grow, when to stop growing. And then you have a happy cell. And if the genetics inside of the cell are fine, they don't have any mutations, then you have a cell that is happy, that doesn't have uncontrolled growth and knows how long to live and when to die. But when you do have mutations, you have uncontrolled growth. And something that's kind of been touched upon a little bit, but I wanted to kind of expand on, is many times patients will ask me, do I have a cancer? And the answer to that question comes with the name. So myeloproliferative neoplasm refers to a cancer. But sometimes I find that the word cancer is too big for these disorders, but they do meet the definition of cancer, and that's because of what I'm going to say now. So when you have uncontrolled growth because of clonal growth marked by a mutation, then that's really the definition of a cancer. And so in all of the MPNs, you have uncontrolled signaling of this pathway called JAK-STAT. So on the surface of the cell, you have this receptor that responds to all these chemicals that are floating around. And when those chemicals bind to these receptors, they basically turn on that receptor and they say, okay, we need more of something. And so then those receptors come together and they activate what's called a signaling pathway down below in JAK and then all the way down to STAT, and then that goes to the center of the cell and makes that cell grow. Now, if that receptor can turn on by itself, then you have uncontrolled signaling and uncontrolled growth. And so no matter what mutation a patient may have, this signaling pathway is activated in MPNs. And so the first mutation that was described was a JAK2 mutation, and that's here inside of the cell. So this is the cell surface over here. This is the receptor, and JAK2 lives inside of the cell. So when it's mutated, it can turn on this pathway. But then the other two main mutations, the calreticulin mutation or the MIPL mutation, also function to activate JAK-STAT signaling. So the MIPL mutation is really just a mutation in this receptor, in the thrombopoietin receptor. And calreticulin, when it's mutated, it also finds its way to this receptor to activate it and activate JAK-STAT. And why does that matter? Yeah, it's interesting. Doctors talk about it a lot. You hear about it a lot. But it matters because this means that if you have a JAK inhibitor available, like Jakafi, for example, any patient, regardless of what mutation they have, can respond. And now you know why. Because Jakafi blocks JAK-STAT signaling. It's not specific for the mutation. And also, it helps us understand why patients have the symptoms that patients have. Because this signaling pathway is a pathway that leads to activation of a lot of inflammatory cytokines, or these, what I tend to call them, as evil humors. So all these cytokines signal through this pathway, and that's why patients with all of these diseases will have a lot of these symptoms like fevers, night sweats, weight loss. So understanding this biology is not just interesting, but it really helps us in determining treatment and also to understand why patients have the symptoms that they have. So another question that I get often is, why did I get this? And that's a great question. Hopefully one day I'll be able to get up here and give you an answer to that. Like I said, there's a few cases that may be genetic, but for the most part, we really just don't know. So how do we make a diagnosis? We follow the World Health Organization, and it was updated in 2016 to make sure that patients meet all of the criteria, because like I said, having high blood counts is not enough. So there's many other reasons for patients to have high blood counts. For example, patients can have high red blood cell counts if they are taking supplements that have androgens, like testosterone. If they have tumors, for example, that produce a hormone called EPO, or in some rare instances, if they live on high altitude. Patients can have high platelets as a response to infection, inflammation, or iron deficiency. And patients can have fibrosis or scarring of the bone marrow as a reaction to infection or to some medication. So it's important to make sure that we've ruled out other causes of high blood counts. And then we've discussed what a bone marrow biopsy is, but really I can't emphasize this enough. A bone marrow biopsy, as painful as it may be, if it's done, I hope, by a specialized provider that does a lot of these bone marrow biopsies, can hopefully not be that painful. But it's really very important to go through a bone marrow biopsy at diagnosis, at least at diagnosis, to establish a baseline, to know what you are dealing with at the beginning of your diagnosis. And like was explained before, a bone marrow biopsy is done by numbing the skin and the hip. Sometimes your providers can give you some other medications to take by mouth or IV to make you a little bit more sleepy. And this biopsy really does help us to know what is inside of the bone marrow. And specifically, we want to see, what do the cells look like? Is there any evidence of scarring? Sometimes patients' blood counts look one way, and we're surprised to find that in the bone marrow there's actually scarring, which you just can't tell that by looking at a patient's blood counts. From the bone marrow biopsy, we also get a variety of other tests. So we do what's called a karyotype, where we take a picture of all of the chromosomes or the genetic chapters inside of the cell to make sure that everything is in order and that all of the chromosomes are where they belong. And then we also test for genetic mutation. So we'll test for JAK2, and if appropriate, for calreticulin or MIPL or other mutations. And I guess I've already said this, but really, I can't emphasize this enough. It is important to do a bone marrow biopsy to establish a diagnosis. All right, so then I'll talk a little bit about each of the diseases. So how do we diagnose polycythemia vera? This was recently changed, and it's, believe it or not, an area of a little bit of controversy in some clinics. So for a diagnosis of PV, patients need to have a hemoglobin of greater than 16.5 if they're men and greater than 16 if they're women. And this has been controversial because there's some patients that have a blood count that's that high but don't actually have PV or have anything wrong with them. And so a lot more patients are being probably screened for PV than before. The older guidelines said had higher cutoffs, so 18.5 and 18. And anyway, so you have to have a bone marrow biopsy that looks like polycythemia vera, meaning it doesn't look like anything else, and a presence of a mutation. And in the case of PV, most patients will have a JAK2 mutation. Minor criteria, but also important to check, is an EPO level. Erythropoietin is a hormone that regulates production of red blood cells, and generally when your bone marrow is making lots and lots and lots of red cells, the EPO levels should be low in patients with PV. So how do we diagnose essential thrombocytosis? Well, the first thing that'll call a doctor's attention is that the platelets are greater than 450 or greater than what's considered normal. And again, a bone marrow biopsy is important when the platelets are high to make sure that it's ET and that there's no evidence of even a little bit of scarring. So in the most recent iterations of the guidelines, there's a new entity called prefibrotic myelofibrosis, where patients just have a little bit of scarring, but not enough to be considered as myelofibrosis. And so the only way to know if that scarring is there is to do that bone marrow biopsy at diagnosis. And again, patients, for the most part, will have a mutation in either JAK2, calreticulin, or MIPSS. There is certainly, and we've heard, a group of patients that have what's called triple negative disease, or patients that don't have any of the mutations. And for ET in particular, we don't think that that impacts prognosis, not having any of the mutations. All right, so this has been talked about a little bit, and you've heard the R-IPSS thrombosis score already, but when thinking about how to treat patients, really the main goal in treating patients with polycythemia vera or essential thrombocytosis is to prevent patients from having a blood clot. My hope is that one day I'll be able to say more than that I'll be able to say that our goal in therapy is to actually cure disease and not just to prevent blood clots. But really the therapies that we have available right now are aimed entirely at preventing patients from having blood clots or bleeding from their diseases. And so when we're talking about risk, we're really talking about risk for blood clots. So patients that are young, that don't have a JAK2 mutation, and that don't have any cardiovascular risk factors are generally thought to be at low risk for having a blood clot. So in terms of treatment, and this is kind of a newer thing, patients that are very low risk are thought to be so low risk if they're young and don't have a JAK2 mutation. And so sometimes we don't even put these patients on an aspirin because we don't think that they warrant that therapy. Most other patients will be on an aspirin, and then we will agonize, and this is where it's important to have a good relationship with your doctor about whether or not patients need to have what's called cytoreduction or medications to improve platelet counts. But having a high platelet count by itself is not an indication for being on medication to lower your platelets. And especially if patients are young, and don't have any symptoms of their platelet count, they're just walking around but know they have a high platelet count, that's not a reason for starting a patient on a lowering medicine. So anyway, now we have actual guidelines from the National Cancer Guidelines Network that actually specifies this out. So if you are treated by a group of doctors that maybe don't see a lot of ET, PV, or MF, you can also go on to the NCCN guidelines to see these also, and that's, I think, very, very helpful. And another thing that's really important, in addition to giving aspirin or giving medications to lower platelets, is that managing other medical conditions is really important. So things like high blood pressure, high cholesterol, obesity, smoking, diabetes, all of those things will contribute to a patient's risk of having blood clots. So managing all of those things is also really important. And although you may be seeing your hematology oncology provider more frequently than your primary care doctor, it is really important to have a good relationship with a primary care doctor as well. So the treatment for polycythemia vera is very similar to essential thrombocytosis. Basically, low-risk patients get an aspirin, and high-risk patients, which are considered patients over the age of 60 or with a prior blood clot, should be treated with, in addition to aspirin, with a medicine to lower blood counts. Phlebotomy, I guess I should have said, phlebotomy is given to all patients to lower the hematocrit to less than 45. And we know from studies that having a hematocrit of less than 45 is associated with decreased risk of having blood clots. But if phlebotomy alone doesn't work, or if a patient is over the age of 60 or has had a blood clot, then those patients should be considered for medications such as hydroxyurea or interferon, in some cases Jakafi as well. So I always like to talk about this, even in clinic. You know, we give this detailed description of this biology of the disease and JAK-STAT signaling and all these mutations. And then when it comes practically to treating patients, we have medications and treatment approaches that really are as old as medicine itself. So we give aspirin, which is not a high-tech medication, and we do phlebotomy. At least we don't use leeches, right? But so hopefully one day we can do something more than just this. So I've sort of touched upon this, but I really do like to emphasize this. In addition to, deciding based on your mutational status if you need therapy or don't need therapy, specifically to lower your blood counts, there are many other things that should be taken into account when taking care of a patient with an MPN. And that is, like I said, having a good relationship with a primary care doctor and managing cardiovascular comorbidities. Anne talked about this at the beginning of the session in the morning, things that are within our control. Not smoking, if possible, having an active lifestyle, doing exercise, and managing other medical problems really can help not just reducing risks of thrombosis, of blood clots, but also in overall well-being. So healthcare screening is also really important, and we were talking about this during lunch. Patients with MPN, in addition to being at risk for having blood clots, may have an increased risk of having other cancers. Small risk. I don't want to make people think that this is a huge risk, but because of that, it's also important to have a good relationship with a primary care doctor. Make sure that you're taking care of everything else, that you're up to date with mammograms, colonoscopies, pap smears, have skin checks, those kinds of things. And then the next thing is really talking about symptoms. We all know that in addition to looking at blood counts and deciding whether or not we need an aspirin or medications to lower blood counts, symptoms are really important and oftentimes will determine whether or not a patient needs treatment. So the MPN symptom assessment form is really, really useful and is something that I use in clinic definitely when I meet patients and then periodically throughout treatment. And I think it's something that you guys can keep track of as well. There are several, it's easy to go online and find this symptom assessment questionnaire. And I really like doing this questionnaire because unlike with blood counts where I can go back years and years and years and track numbers, with symptoms it's much harder to do. But if I follow an MPN symptom assessment questionnaire, I can actually turn in the symptoms into something that is measurable. And so I can keep track of patient symptoms over time and decide, is it time to give a medication? Is the medication working? And then it really just helps me have a better and more focused conversation with my patients. Sometimes you think you're asking all of the questions, but it's easy to forget things like, are you having difficulty with concentrating? That may not be one of the questions that comes up in conversation otherwise. So I really do like doing the MPN symptom assessment form, and if you haven't had these questions asked, then you should ask your doctor to go over this with you in your clinic visits. So in terms of outlook, like we've discussed, the main risk with PV and with ET is having blood clots. But certainly, these diseases are seen often in oncology clinics because there is a risk that they will transform into either myelofibrosis or to acute leukemia. Thankfully, transformation to leukemia is rare. So with that, I'll talk a little bit about myelofibrosis. So myelofibrosis is diagnosed with a bone marrow biopsy. The bone marrow biopsy needs to be consistent with myelofibrosis, mainly that it has scarring. and can't meet criteria for other diseases. And for the most part, patients will have mutations, either a JAK2, a CALR, or MIPL, but there's definitely a group of patients that don't have any mutations. And somebody asked me about that during lunch. What is it about those patients that don't have a mutation? Do they still have myelofibrosis, or why do they have a worse outcome? And we don't know. Probably most patients do have a mutation. It's just that our testing doesn't know how to test for that mutation yet. So in addition to having the mutations, patients should also have either anemia or a slightly high white blood cell count. It can also sometimes be very high, actually. Patients can have splenomegaly or an enlarged spleen, and have a high LDH, which is just basically a marker of cell turnaround. And then I spoke about this a little bit before, again, to kind of make the point of why it's important to do a bone marrow biopsy. There's this entity that's called prefibrotic myelofibrosis, where basically the patient's blood counts may look like ET, but when a bone marrow biopsy is done, we see that there's a bit of scarring. And it's not just that it may not affect exactly how patients are treated immediately, but it does make doctors, or should make your treatment team, think a little bit differently and say, this person's outcome is still very good, but we just have to keep an eye on this patient a little bit more closely just to make sure that they're not actually transforming to myelofibrosis, because the risk of transformation to myelofibrosis is a bit higher if there is some scarring on that initial bone marrow biopsy. So then, risk stratification. So we talked a little bit about risk stratification and PV and ET, and really the main goal there of risk stratification is to prevent patients from having blood clots. In myelofibrosis, it's a little bit different. And we use risk stratification, and it should be used in every patient to help determine how we treat patients and to really help in talking about prognosis. But it has gotten a little bit ridiculous in the last couple of years, which is why I put this here. So, we used to use the DIPS, and then there's the DIPS Plus, and now more recently there's been other risk stratification models that are starting to be used, the JIPS and the MIPSS. So I was like, too many acronyms. So anyway, the one that's most commonly used is called the DIPS Plus. Pretty easy to use. Also, your doctor or whomever's treating you can go online and look at, calculate risk factors based on very easy to find variables. And so this takes into account things that make sense. Age, if blood counts are low, if the white blood cell count is very high, if there's stem cells or blasts, like these immature cells that are circulating in the blood, and if patients need transfusions, as well as patients' genetics. And the DIPS really helps to divide patients into different groups. And it's important to use this because if you see patients that have low-risk myelofibrosis have a very different outcome than patients that have high-risk myelofibrosis. And so here I just am mentioning the MIPSS, mostly just to say that although treatments may not be very different depending on different mutations, we are getting a little bit better at understanding what mutations do in terms of prognosis. And the next step, of course, will be to use mutations to help really direct therapy. So the MIPSS, unlike the DIPS, actually calculates in mutations like JAK2, JAK2, calreticulin, and MIPL, but also other mutations. So depending on the testing that's available where you're treated, many providers will test for many other mutations, such as ASXL1, TED2. There's many other mutations that are now almost becoming routine practice in some places, and we're starting to integrate those into how we think about our patients. So treatment approach. Basically, patients that have myelofibrosis that don't have any symptoms can be observed. And this is really important. There is no benefit to giving therapy early. And so these are patients that can be monitored expectantly. If patients have symptoms, and I'll divide symptoms in two categories, either symptoms related to blood counts or symptoms related to these evil humors, the cytokines. So if patients have fevers, night sweats, weight loss, itching, or symptoms related to a spleen, really the best drug for those patients is ruxolitinib or Jakafi. That's the only JAK1/2 inhibitor that is approved for clinical use, and that helps to really reduce spleen size and improve symptoms. Now, if the problem that's going on is more related to blood counts, then it's a different situation. And so for low blood counts, we have medications such as EPO, which is that hormone that helps to make red blood cells. We have other medications such as testosterone-like drugs, or other medications such as the immunomodulatory drugs, lenalidomide or thalidomide, with or without steroids, that can sometimes be helpful for managing low blood counts. That being said, many of these medications may work for a period of time, but are not curative. And so patients that have really low blood counts that need medications to make those counts go up should at least start thinking about talking to a bone marrow transplant doctor. The only curative therapy that we have available for myelofibrosis today is a bone marrow transplant. And if a bone marrow transplant is not thought to be a possibility, then clinical trials are also a good consideration. But this is definitely an area that requires new therapies and a lot of research. So I guess I talked a little bit about this. Basically, divide your symptoms, your treatment, depending on whether or not you're dealing with symptoms or dealing with low blood counts. And so one thing that's important is that patients should not be put on a JAK inhibitor because they have a JAK2 mutation, and I get that often. Really, patients should be on a JAK inhibitor if they have symptoms of splenomegaly, a big spleen, or these systemic symptoms. And then the other thing that I really can't overemphasize is it's easy to get up here and talk about low-risk myelofibrosis, or even the other two, ET and PV, and say, follow up with your doctor as needed. But living with a chronic disease, and I don't have to tell you this, can be very stressful. And I often find that patients that know that they have low-risk myelofibrosis or are very educated, like yourselves, you're active, and and patients that know that they have a risk of this becoming something else, that can be a really big deal also, just dealing with that chronic illness. And so what I always like to say is, although today we don't have therapies that can modify disease, that can cure it or can prevent these things from happening, there's a lot of research that's going on. So the first thing is, remember, there's really a lot of room for hope, and I'm not just saying that, I really think that's true. But also, it's important to have a good relationship with your doctor so that even if you're not talking about therapy, or even though you may not need therapy, living with a chronic illness does have a lot of its own issues, and it's important to be able to actively communicate with your doctor about those things so that you can get the support that you need. That's it. Thanks so much.